I'll call the meeting to order. Any disclosure, any peculiar interest? Seeing none. Approval of the minutes, March 3rd, public health meeting, as presented. June, and I have a seconder for that. Guy, anybody opposed? Carried. Okay. And first up is Dr. Mercer in our update. There you go, Dr. Mercer.
Yeah, thank you very much. Hard to know where to start because things have changed so much over the course of a month.
I know.
So if we go back in time, you will remember that we were looking great. And we actually, probably about the time of the last board meeting, we were orange. We actually slipped into yellow. Then we went back into orange, and the province allowed us to move to orange after a 2-week, which is typical for the province. So we moved to about a 2-week period of time, and then the province has put us in lockdown. And so as a result of that, and just prior to when we moved into lockdown, I'm just going to pull up on my, I don't think you're going to be able to see my screen, so I'm just going to look at it and read it to you. So this morning, if you were to look at what happened, and this is a point in time that occurred over less than 7 days, we went from 40 cases, that's our moving average per 100,000, to this morning we're sitting at 108. So almost 3 times the 7-day moving average for confirmed cases. Our test positivity also has tripled. It's 4.4% now, and that number is even higher in younger adults and school-aged children. Our reproductive number is sitting at 1.43. That's the highest it's been since the beginning of November. These are all extremely worrying trends, and they're not completely equal across Wellington, Dufferin, Guelph, but they are fairly equal. So Wellington and parts of Wellington is a little bit better than Dufferin County, especially Orangeville, especially our urban areas tend to have higher cases, and city of Guelph as well. But the county of Dufferin has also got very high numbers of cases right now. So these are all extremely new and rapid changes. The interesting thing about what's happened in this particular 1-week period is the rate of rise. So if you looked at what happened in the second wave, what we saw was a very slow, I call it slow burn. We slowly crept up over many weeks. We peaked about the first week of January, and then we slowly crept down. This is quite different. Actually, it's remarkable how different it is. We have been, and have been, as I said, for weeks, we're very consistently orange or yellow. And then in the space of just a few days, the sudden change. And what's driving that sudden change? Well, as of yesterday, I don't have today's information in front of me. As of yesterday, 60% of our cases are the B117 variant. That is the UK variant. And we know that this particular variant is highly infectious, and it is driving the predominant amount of cases that we're seeing in all parts of Wellington, Dufferin, Guelph. And if it's 60%, it will very quickly move to 90%. You've seen other countries, you see what has happened. UK was a classic example when it moved through there, and any other country that doesn't have high rates of immunization, you see that very, very rapid rise in cases. In particular, what we're seeing is that the cases that are coming into our hospitals, and our hospitals locally are impacted by this, the week over week change at the Guelph General Hospital has also been quite remarkable in the numbers of inpatients, but the people are younger. The average age at the peak of the second wave for people who are in the ICU was about 70. The average age for people up to this point, and it's only, remember, we're only just starting the third wave, the average age has dropped to 64. That's quite a dramatic drop, and it could drop even further as we move into this wave. So whereas we had some comfort in the second wave, that this was really a disease of older people, and most of the people who were ending up in our hospitals and in our ICUs were between the ages actually of 60 and 74. What we're seeing now in this wave is that it is younger people, so people in their 30s, 40s, and 50s are starting to get COVID. We have had in Toronto, we've had children lose their parents, not their grandparents, their parents to COVID. And so that is something that is really important that we prevent and try to stop the spread of COVID in our area so that we can keep our families healthy and well. So locally, I'm sure the board knows that I made a decision on Monday evening in collaboration with the school boards. So I just thought I would share a little bit about that process because I know that some of you were wondering how that occurs. So I could tell this process began about Thursday. So I saw an increase in cases on Thursday. We'd seen some minor increases over the week before that, but again, sometimes in a pandemic, you see things go up. You also sometimes see them go down. So you can't take any short period of time. But I noticed a change on Thursday, and I noticed that we had a significant number of cases. And so I continued to follow that over the course of the weekend. And what I could see happening was something that we hadn't actually seen in the previous wave. So I saw and I monitored over the weekend. I thought this looks different, dramatic increase in numbers of cases. We had 100 cases reported in one day. So on the Monday, I asked our data scientists, Justin, he's a PhD data scientist, to actually look at our numbers locally and tell me what you're seeing. And based on that, we knew that at that point in time, this is Monday numbers, that we had 300 new cases, that we had closed more classrooms in any one day last week than we had throughout the entire pandemic in a single day, that the 7-day moving rate of cases just for our school-age children at that point in time had gone from 25 to 100. And we know it's probably higher now. The percentage positivity in school-aged children had increased by 3 times. And in that same period, just for our population, I told you the RE had gone to 1.38. And the rate of these changes were significant. So we could see that. We could see what was happening in our classrooms. To date, I think we have 33 classes, like whole cohorts of children prior to on Monday that were off and had been dismissed. That's a lot of children affecting a lot of schools. And so moving forward, I decided we need to speak to the school board directors of education. So on Monday evening at 5 o'clock, I met with all of our directors of education. They all met together at the same time. We called an urgent meeting to really discuss what they were seeing. And they were saying the same things. And in fact, they were actually having trouble actually operationalizing this because they were having so many teachers and so many cohorts being sent home that at some point in time, they were actually having to close classes anyways because they didn't have the people to the teachers and they couldn't get replacement teachers because replacement teachers will often ask the question as to why is there a replacement, and if it's because of COVID, a number of those teachers don't necessarily want to enter a COVID school, predominantly because teachers, remember, are not vaccinated right now, and so it's a risk to them and their families. So based on that, and with discussions amongst all the school board directors, we decided to close the classrooms on Wednesday, not on Tuesday. We felt that operationally that was not fair to parents, that some of the school boards were comfortable with that, thought they could do it, but I think overall we felt that it was better to operationalize this on a Wednesday, similar to what the Toronto District School Board has done in closing their schools on a Wednesday. And there's only 2 ways that you can close schools, other than for operational reasons. The only ways to do that are for me to issue an order to close schools or to issue a letter of instruction, both of them under the legislative authority of the Medical Officer of Health in order to do so, which is what I chose to do. And the order was written. And the directors of education knew it was coming, and they were all well aware of it. And they were given permission to tweet and talk about it on Monday evening in order to give parents as much notice as we could so that they were prepared for Wednesday. And clearly the letters and the complaints started after that. Is a bit discouraging, but I also understandable that parents were not happy. I think that it's understandable to be not happy. It's really understandable when you want your children in school. We all want our children in school. I think we all want this pandemic to be over and ended. And yet it's not. Here we are facing a 3rd wave, which all predictions are that it will be much worse than the 2nd wave. Currently, we have in the province of Ontario, we have over 500 people on ventilators in the ICU. And some of that is because we never got people on ventilators from the second wave. So we still had people in ICU at the end of the second wave, and now the third wave is hitting. So we didn't have the distance between the first and the second wave was quite far. So we didn't actually have that issue, but because the period of time between the second and the third wave was not that short, and people who end up in ICU with COVID can be there for months. So it's not a short period of time. So as a province, we're preparing for 700 ICU cases and vents. I think that's what they are prepared for, and that we have the capacity in the province. And let's all hope that we certainly don't need to have those number of ICU vents across the province, although we are over 500 now. So this is really the state of where we are and the state of what it looks like locally. So it really is probably not a surprise that we have such significant variance and that you can see these variants spreading locally. It has in every other jurisdiction of the world. So Canada is not unique. Ontario is not unique. We're seeing this. And we're also seeing that it in particularly impacts neighborhoods of density, neighborhoods where people have to go to work. So that is one of the things that we continue to see is that apartment buildings, people who live in multi-generational families, the more people that you have to live with, the more people that you have to work with in close contact. These are all of the things that put people at individual risk. And so that's why we see some communities are hit harder than other communities. And the province today has announced just in this afternoon, a few changes to try and support that. So they're going to be looking at things like providing vaccine to special education teachers. There's going to be a certain list that the school boards are going to provide us in order to ensure that we know who qualifies and they will get the vaccine. And then that there might be teachers in FSAs or hotspot areas. FSA is a forward sortation area, and it's really a postal code that's used to look at where do we have increased amounts of disease. And Wellington and Guelph has one of these FSA areas in our community. It's in Guelph. So based on that, what we can do is look at who lives and works in this FSA area and try and target vaccines to that particular area. Now, what it doesn't mean that people who don't live out of that area, don't have risk either. It just means that these areas are particularly impacted by COVID, and predominantly by rates of disease. So what we're trying to do is compensate by increasing vaccination in the areas that have increasing levels of disease. So that's one topic. And then probably moving on, and then we'll come back for questions, is since the last board meeting, the ministry, and I think the ministry had announced this, but we hadn't actually implemented it yet. We'd moved from a 21 to 27 day timeframe to a 4-month or 16-week timeframe between first and second doses. This was a broad decision, so it began with NACI's recommendations and the provincial government implementing this at 4 months. Today, NACI actually came out with another statement and looked at the science and evidence and continues to stand by and support the 4-month interval. So this is now and the latest one that was released today was looking at all the science and the papers to date, and they still retained the idea that for most people, with a very few exceptions, for most people, that retaining the 4-month interval is appropriate and the ethical thing to do. I've had many people who've tried to jump the queue, many people who think that they are entitled to 2 doses. They are entitled to 2 doses, and even if other people get 0 doses, they are entitled to 2 doses, even if it means that other people die because they couldn't get 1 dose. And I don't support that, and I think the government made the right decision to ensure that everybody has an equal opportunity to get 1 dose before we give second doses. The important thing to note about 1 dose is it's highly effective at preventing severe disease and death, highly effective. So we can save lives by giving people 1 dose. I think that's the most important thing. So it was based on the science, and it was based on the medical ethics, and I continue to think that that was the right thing to do in an environment of vaccine scarcity, because we don't have the vaccine we need. If we had the vaccine that the US or Israel or other countries did, then perhaps we would be making different decisions. But we have to make the decisions that we do in our environment of vaccine scarcity. And obviously that could be subject to change if the vaccine scarcity changes or if the science changes on that. But the review by NACI today was quite reassuring, and everybody who's had one dose should be very reassured about their protection with one dose. And everybody who's had one dose will receive a second dose at the 4-month interval, and that is planned. So, but in that interim, we have an opportunity in Canada to also vaccinate everyone with one dose and that needs it, so that we can provide enough coverage to end, to definitely make an impact on this pandemic. And the interesting thing is, if you look at countries like even Israel, US, Britain, countries that have pretty high rates of coverage where not everybody has a second dose. Some do, I'm not going to deny, some do. The US has a policy of 2 doses. They also produce and do not have vaccine scarcity, but the UK did have some vaccine scarcity, and so they followed also a prolonged interval, 3 months actually in Britain, and we have the studies out of there. And so you can see that it made a huge impact on the pandemic in terms of, and they are now slowly starting to get back to normal, which I think here in Canada we would just, we're dreaming of and hoping and knowing that we're still at least 8 weeks away, based on current vaccine projections, from approaching any form of coverage that would allow this pandemic to start to decline. So I think that's important. I just want to also, before you ask questions, just talk, we're going to do a vaccine clinic update. So if you have questions about how much vaccine, where it's going, our vaccine plans, maybe we could just hold those to after the presentation, because I suspect that you're going to find that the presentation will answer those questions for you. But if you have other questions other than the vaccine rollout, I'm happy to answer them for you.
Dr. Mercer, and I was going to make mention of that because, yeah, if we can hold the vaccine ones until later. I'll open it up for questions now for the board. June.
I believe I'm muted. Thank you, Kyle.
You're good. You're good, June.
Okay, thank you. Yes, I'm looking forward to a larger discussion about the vaccinations, so I will hold my questions about the vaccinations. But that brief update you gave us, Dr. Mercer, I found that very informative, especially hearing that one dose is highly effective. I think we can't hear that enough. My question is about, I'm wondering, when you were talking about, you spoke to closing the schools, and I think what there's a lot of confusion about in the public is who makes that decision to close the schools. And you said right from the start of your presentation that it was a collaboration with the school boards, and it was based on data and science. And I was really happy to hear that, because I don't think people understand there's a whole process to what you do, and it's not just Dr. Mercer. You have scientists at public health, you collect data, you work in collaboration, which in this case was the school boards. Could you maybe just speak to that a little bit, how those decisions get made so people in the public can understand that?
Thanks, Jen. I'm sorry if I wasn't clear. So yes, so there's
Excuse me, you were very clear.
Oh,
I just wanted everybody to be on the same page, Dr. Mercer. Thank you.
So,
Kyle, can you unlock Al All's video?
I told him not to lock himself out there. Okay, there he is.
Sorry to interrupt. Ooh, there he
that's
is.
fine, Chris. So one of the things about school closures, there's only so many ways you can actually do it outside of a snowstorm or an operational, you don't have enough teachers. So that allows the school boards to close. But a school board can't close due to disease or an outbreak on their own. So the directors of education don't have the ability to actually close a school for those particular reasons. So for operational reasons, for safety reasons, something happens in the school, those are things that directors of education can do. So the way that the legislation is, a medical officer of health has the ability to close a school based on two ways, either using the HPPA with a Section 22 order or using the Emergency Measures Act with letters of instruction to our school boards. And so right now in the province, there are 3 Section 22s for school closures. There Toronto District School Board, there's Peel, and there's us. We've all closed the schools using Section 22 orders. And in Northern Ontario, there's actually at least 2, and I think more health units that have issued letters of instruction to their school boards since March. And so those schools have been on virtual only for quite a few weeks now, based on letters of instruction. Those are the only 2 legislative tools available other than the minister closing. Now, if the minister closes, I have no authority to open schools. Sometimes people beg me to open the schools when the minister has closed the schools, and I do not have that legislative authority. I cannot undo things that have been done by the province, rightfully so. I can only look at what is happening locally and use my local authority to try and mitigate the spread of disease and for the health and well-being of our children and our adult population.
Thank you very much for the clarity.
Thanks, June, for the question. And anybody else on the board want to ask a question? I see somebody, Jake, with a hand up. Now, I just want to let everybody know that's on here as a participant that there's no questions from the audiences in this particular thing. So if you're wanting to ask a question, I hopefully will give you enough information based on our reports and get some clarification that way, but it's just for the board to ask questions. Okay. I just a comment, Dr. Mercer, and it's unfortunate that people's emotions are running high. This isn't going to be very popular. I know I just had a meeting with my department heads because we just got the next notice and some of the things. And I've had many questions from people. And I think your comments today are very important because I think that's what we have to look at. We have to look at the science. And I know people have disagreements on science, don't get me wrong. But at the end of the day, we go by rules and regulations that are set down to us as well. But I give this, you and your staff so much credit over the years, over this year, because we were one of the first to put masks out there. We took a lot of heat for that. If you remember, it's been a long time, but we took heat. And guess what happened? People followed up and everybody said, well, what are you doing? And I wouldn't be surprised if more school boards they may not do this 3 days of not closing now, but I think that's very important. We did that. But I would be surprised if we might not see the schools not open up after this break, because I don't think we're past the tough situation that we're in. And when you explained to me the other day about the age bracket of this new variant and how it's affecting the parents, where before they were just being, a small infection, not a big deal. We were more worried about the grandparents and the seniors. And now we're in that situation where this variant is very deadly. And we're seeing the stats. We're seeing the stats of how many people under 50 now are in our ICUs and are now dying. And you're right, they're parents, and the kids could get sicker too. So, you know what? It's some caution. And I know you're going to talk about vaccines later, which is more of a positive thing. So I'm going to let that go at that time. But from a board standpoint, it's unfortunate they're taking so much criticism, and it's not fair. And I just like to put that out there.
Thank you, Judge.
Did you have another question?
Yes, I do. Thank you, Mr. Chair. Dr. Mercer, I was just wondering 2 things. Could you update us on the outbreak at Wellington Terrace?
Yes, I could. Thank you. So it is a very interesting outbreak. So the outbreak actually has people who aren't sick, but who've tested positive. So I think the first important thing is that this is not any illness in the residents. This is to do with surveillance of staff. And we had 5 staff who've all tested at very, very weakly positive levels. So only one of them, the level was enough that they can probably go forward and see if it's a variant. So, but based on that, all of the staff are doing well. We're also, obviously they're living in households with partners. And so we're also monitoring the families that they're with. All of these staff members have been vaccinated, which I'm sure is why they're doing so well. But it's very interesting, and we've had Public Health Ontario involved in this because we wanted to make sure that it wasn't a contaminant, so they retested and it's actually correct. But it's a very interesting situation. I think the important lesson, though, out of all of this is that the vaccines work for protecting people from severe disease and death. And so what we've seen in our long-term care homes and retirement homes has really been nothing short of remarkable. We had so many outbreaks in our long-term care retirement homes, so many people dying, people being restricted, having to have very strict public health measures to try and keep the virus out, and we're not being successful. And yet, since we vaccinated, and we have very high levels of vaccination all across the province and locally as well, more than 92% of our residents, and in some areas it's even higher than that, have been vaccinated. Very few have not been vaccinated. And because of that, we've practically eliminated outbreaks in our long-term care retirement homes. The staff levels of immunization are variable. Some have higher rates than others, not as high as the residents, but they are slowly creeping up, I think, as people feel more confident to get the vaccine. But where we're seeing cases is mostly with unimmunized staff testing positive, and then and then that's a way to put the home now into a suspicious outbreak. Up until yesterday, it was an outbreak, but as of today, they changed the definition, and now it's a suspect outbreak.
Thank you for that, Dr. Mercer. And one more quick question.
Sure.
Well, maybe it's not quick, but so I'm just curious about, we hear when there's an outbreak at the Wellington Terrace or the St. Joseph's Hospital or wherever it may be, the General Hospital. But I'm curious, and maybe I should know the answer to this as a board member. If there was an outbreak, say, staff at Costco or staff at Walmart or staff in a mall, or people going to malls and contracting COVID, is there a list of those super spreaders posted somewhere, or is that a human rights thing? How do people keep updated? Like, I better not go to Costco today because there's 50 people in a lineup and they have an outbreak. How are we giving assurances to our residents that where they go affects the spread of COVID?
Well, I think starting tomorrow, I don't think there's going to be quite as many places that they can go with the stay-at-home order. But to answer your question, the first thing is that if there is a risk to the public, we absolutely report it, and we have to report it widely so people know and can get tested and can self-isolate. So that threshold of risk to the public, we do report on outbreaks, and we report on them in aggregate numbers. So they've been on our website for a long period of time now, so you'll see that. And early on in the pandemic, we try to make a decision as to how we should report on outbreaks, because some of these outbreaks are quite small. So let's say you had a small business, whether it's maybe a drive-through or a little restaurant, and you have 4 people in the restaurant. It's pretty identifiable if I say, restaurant ABC has an outbreak, because now you all of a sudden know who the 4 people are. So it's quite identifiable. It's a bit different if it's a large outbreak. So we made the decision for outbreaks where there was no risk to the public. So we knew that based on who the infected case was, where they worked, where there was no risk to the public, we didn't report those. We reported them in aggregate, so we counted them together. Yes, there's a restaurant outbreak. But if there was a risk to the public, if we couldn't rule out that there wasn't a risk to the public, and we have done that, we have reported on outbreaks in areas where we want the public to know that there's an outbreak in this place, so the public is aware and says, hey, I might have been exposed, I might have been at that place. So we do report outbreaks based on the risk to the public.
So only if there's no risk to the public. Okay, thank you. That's very informative.
Ralph. Go ahead, Ralph. You might have to get unlocked. I might have to unlock you. There you go.
Unlocked.
Thank you. I think I know what the answer is here, but I think it'd be important for you to tell us. There's a question that I get not increasingly frequently, and that is, how can I protect myself from the new variant?
Great question, Ralph. So I think that there's two parts to that. There is the public health measures, and then there's vaccination. So so the first thing is that for people who are eligible to be vaccinated, please get vaccinated. And why is that? It's because locally the B117 is the variant that is circulating, and we know that all of the vaccines that we are offering locally, which we've only there's three. We have the Pfizer, the Moderna, and the AstraZeneca. All of them work against the B117 variant. So that is one way to protect yourself, sort of a way of ensuring that you don't get sick. But then there's the other measure. So what if you're not eligible yet for vaccine and you're still waiting? How do you protect yourself? So these variants, the measures are actually the same as what we've always done. It's just they have a lower tolerance for error. So whereas in the past with the wild type variant, you might have been able to get away with having that quick little, what I call coffee chat. So you're at work and you stop in the hallway, you're maybe a little closer than 6 feet. You maybe because you're drinking a coffee, you don't have your mask up and you're having that little 15-minute chat. In the wild type variant, you probably or possibly could get away with that. With the variants of concern, especially this new one, the B117, that is not likely that you could get away with that. And we believe that it could be as short as a few minutes of exposure could result in you getting infected. So the most important thing is for people to just be much more vigilant and careful with their measures. So keep your distance, keep 6 feet apart. Wear a mask. The best mask that you can wear is the one that you will wear. So it's comfortable, it fits you well, it covers your nose, your mouth. It's made of at least 2 layers and is clean. So those are the criteria. So the one that you like to wear and is the most comfortable to wear for you is the best mask for you, and keep it clean. Stay your distance, keep your hands clean. And those are really the best way to protect yourself. And if you don't have to go out, don't go out. That's what the stay-at-home order is about. So if you can order your groceries online, order your groceries online. If you can order whatever it is you need from a store, support our local businesses, but order online, use their websites, and then pick up. That would be good.
Thanks, Dr. Mercer. Okay, I think we're going to move on to the next report, and it's I think Rita, you're doing this. So we don't make them. We don't have to. That report doesn't have to be first now. Okay. So Rita, you go ahead and talk about what we're all listening about. And I know you've been very busy at this. And I have had my vaccination, and I got it 2 weeks this Friday. So I'm feeling really comfortable about tomorrow or Friday being a great opportunity for me to. Well, I'm not going to be perfect, as Dr. Mercer said. You still have to do everything else, but the troops in Fergus that did an amazing job. So hats off to you for that, Rita.
Well, thank you very much. And thank you everyone for giving myself and Kyle the opportunity to do this presentation. So I'm going to do the first part of the presentation, which is going to talk about our vaccine rollout from the very beginning. And then Kyle's going to talk and focus the attention on how are we moving through the phases? How are we picking the people that need to be vaccinated? So next slide, please. So we're going to do a bit of a timeline here. We received our first shipment of vaccine on the 6th of January, and that was a Pfizer shipment. And we actually vaccinated our first individual with the Pfizer vaccine that same day. We had our first mass clinic at the Chancellor's Way site on the 7th. And then later that week, we received our first shipment of Moderna vaccine. And it's really important, the timeline here, because we weren't able to move Pfizer. Once it arrived at a site, it had to stay at that site and it had to be administered. We actually couldn't even move it up 2 floors. So we received the vaccine in Chancellor's Way, for example, and we couldn't move it up beyond the first floor. We had to administer between the basement and the first floor. That's how tight the restrictions were. But when we received the Moderna vaccine, we were able to move that vaccine right away. And we were able to go and start vaccinating on January 14th, our long-term care and retirement home residents. And then after that, we received, shortly thereafter, we got the ball rolling. We were out there vaccinating. We got notification of that Pfizer delay that sort of put a halt to all of our vaccination clinics. But we forged on, and we were able to get all of our long-term care and retirement home first doses complete by January 27th. And that was a pretty exciting time because we were right in the thick of the second wave, and we saw lots of outbreaks, and we saw lots of cases in the community. And so getting that particular population covered was quite exciting for us. Next slide. So then on February 1st, another exciting day was when General Hillier and the Vaccine Task Force came on site and actually did a tour of our Chancellor's Way site and determined that the way that we had our clinics set up was a best practice site. And that was pretty exciting for us because we were one of the first health units, actually the first health unit to receive Pfizer, but also the first health unit to be administering vaccine. Prior to that, it was all the hospital sites that were administering vaccinations with the support of public health units. And then on February 4th, we were able to start our second round of long-term care homes and retirement homes. And the 15th was another special day because that's when our Pfizer shipments resumed. And that week on the 18th, we were now able to move Pfizer and Moderna, and we were able to then host clinics offsite. So we were able to do a clinic, our first mobile clinic at Headwaters Healthcare Center. And then we also had a clinic, it says here on the Fergus Sportsplex, but in reality, it was actually at the old Groves Hospital site that we had our clinic that week. And then the other important date in February was the 24th of February, where we had finished all of our long-term care and retirement home second doses. And as Dr. Mercer indicated in her presentation earlier, we're at a 92% rate with our long-term care and retirement home residents. And you can see the benefits of it right now, particularly as we're seeing our case counts go up because it's not our residents that we're seeing the cases in. And that's a really good feeling. The case counts isn't a good feeling, but knowing that we have a good level of protection with that very vulnerable population is very exciting for us. Next slide, please. So then March 4th is an important date because, as Dr. Mercer indicated in her presentation, we had multiple changes to the frequency or the interval between first and second dose. And it was on March 4th that it was flagged to us that we were to stop giving second doses and to have that interval extend to 16 weeks. And that is the interval in which we are working with from March 4th onwards. March 11th is another very important day because that's when we had one of our first community partners open their clinic, and that was the Linamar Clinic out at Skyjack on Woodlawn Road. And then the following week, the University of Guelph, in conjunction with the Guelph Family Health Team, opened their clinic site at the University of Guelph. But we also moved our clinic from the West End Rec Center over to the, moved it from Chancellor's Way over to the West End Rec Center. That was also the week that we ran our clinic at Alder in Orangeville, and a couple weeks earlier is when we had our clinic move from the Grove site over to the Fergus Sportsplex. And then the last important date in March is the 17th of March, where we received our first shipment of AstraZeneca. And that was where we were part of a pilot amongst a handful of other health units that we gave AstraZeneca to physicians to administer. They had a very short time frame to administer this vaccine, and they did so extremely successfully and administered 4,500 doses in a 2-week period, which was pretty phenomenal because they did not have a lot of time to pivot and make the adaptations to their normal office practices to be able to schedule that many people into their office appointments to get AstraZeneca. So our physicians really stepped up to the plate on that one. Next slide, please. So this is an important slide. So this is extremely important, particularly for the Board of Health to understand how we're rolling out our vaccine in our community, because I talked a lot about the fact that we have these large hub sites at Fergus Sportsplex, the Alder site in Orangeville, and then Linamar, West End Rec Center, and University of Guelph. But we also have, we're also administering vaccine in other ways. And what this will do is create a blanket of opportunity, but also a blanket of coverage across all of our communities. So we have our pop-up sites. We have a team of nurses and support staff that will go and administer vaccine in unique locations across our community. To date, we've had pop-up clinics in Drayton, in Mount Forest, in Palmerston, in Arthur, in Shelburne. We're looking to add more of those in Shelburne and in Grand Valley, but we're also looking at other ways or other areas that need to be targeted because their vaccine coverage doesn't meet the rest of the community. We have specialized clinics at our 3 office locations, and that's for families and for individuals that are not able to attend our mass clinic. They're not homebound, so they're mobile, but they can't attend our mass clinics because they have disabilities that would make the mass clinic very uncomfortable and very challenging. We have mobile clinics for our homebound clients that are run in Wellington and Guelph by our EMS, and then in Dufferin by our EMS. And so they are actually going into people's homes with single doses of vaccine and administering the vaccine to keep those homebound individuals safe. We continue to do mobile clinics that are long-term care and retirement homes because, as you may appreciate, that the residents of those homes move in, move out for a variety of reasons. And so when someone moves into a home, we want to make sure that they have the same protection as the other residents. We're setting up and starting mobile clinics in our congregate settings for our special needs populations there. This week, our pharmacies started to offer the AstraZeneca vaccine. We have 10 pharmacies that are up and running, offering that vaccine. We're working with our local hospitals to get them vaccinating, and a milestone was 2 weeks, I think it was about 2 weeks ago, Homewood was able to receive 200 doses of vaccine from us to be able to vaccinate all of the people that are in the Homewood Healthcare Center right now to get them protected. I talked about the physicians' offices. They were pilot sites. They are no longer pilot sites. We received 3,200 doses of vaccine this week that we're administering or distributing out to our physicians to be able to continue to vaccinate. And then other healthcare partners. And 2 that I'll mention are Arch has been out vaccinating on our behalf, and the Guelph Community Health Center has been very integral in getting our homeless population plus our shelter staff vaccinated to keep them protected. Next slide. So who are we vaccinating? So we started in January, and it was a really tight, narrow group of individuals. It was long-term care, retirement home residents, staff, and then we added very unique populations within our hospital that were at risk because of the nature of the work that they do. And that increased dramatically after the first sort of dip in Phizer vaccine, and it moved to adults over 80, Indigenous adults and their household members, long-term care retirement home staff and residents and their essential caregivers, adult recipients of chronic home care, and healthcare workers and emergency responders across the board. So every single week or every other week, we increased who we were receiving or who we were inviting to come to our clinics to get vaccinated. At first, it was a really cumbersome process where we reached out to long-term care retirement homes to get lists of who worked for them. Hospitals gave us names, other agencies gave us names that were appropriate, and we were able to flip to our registration system that Kyle will speak to in a few minutes. That made things a lot easier and has really expedited our ability to vaccinate people that are most appropriate. So phase 2 added adults between the ages of 60 to 79 years of age, congregate setting staff, residents, and select primary caregivers who weren't in the first phase, which is any congregate setting that wasn't long-term care or retirement home, individuals with very specific chronic health conditions, caregivers for those individuals, and then the last part is essential frontline workers who cannot work from home. We are still in phase 2, but we're moving quite well through the adults 60 to 79-year-olds. our congregate setting staff, residents, and select primary caregivers. And we're now working with our individuals with chronic health conditions with the support of physicians and their caregivers. And we're dabbling, and I say dabbling very delicately because the province has given us some new direction around who some of the essential frontline workers are that we need to pay attention to and offer vaccines to. Next slide, please. So it's important to understand our vaccine capacity. So we are running our clinics on average about 10,000 vaccines a week is what we're seeing and what we're planning for the next 4 weeks. But we have the ability to scale up pretty dramatically and pretty quickly. So our anchor sites, those are the Alder Street site, the Fergus Sportsplex, the West End Rec Center, Linamar, and the University of Guelph, have the ability to scale up to about 2,000 people a day. Our pop-up clinics, those are the ones that show up in our variety of remote communities like Shelburne, Mount Forest, Palmerston, etc. We can do upwards of 300 people a day. And then the support of our mobile and partner sites, we can do 10 to 100 people a day. And so with this combined, we can easily do 10,000 or more people a day if we had the vaccine supply available. We do have the staffing to do it. It's weighing on, it would be weighing on us, but if we were to get 10,000 doses of vaccine a day, we'd be done pretty quickly. And I can assure you that the staff of WDG PH would be very happy to get this done as quickly as possible because they know what the benefits to our community and to our pandemic response would be. Next slide, please. So this is what our projected supplies are for, missing a number there. We're supposed to be getting 7,020 doses of Phizer each week, and we're very confident that we will receive that every week. Moderna, we're supposed to receive 5,000 doses this week, and then 2 weeks later, another 5,000 doses. And Moderna is, we have less confidence in the delivery date, and so we are planning how to use Moderna when we have that vaccine in our freezer. And the reason for that is that there's some shipping issues that tend to happen, and so we'll be told we're going to receive the Moderna on Monday, and then it doesn't come until Thursday or Friday. If we plan to use it on Tuesday after the Monday supposed delivery, it becomes problematic because we don't have vaccine and we'd be canceling people. So now we're waiting for Moderna to be in our freezer before we actually implement the plans, but we have lots of plans to use this Moderna up. And then AstraZeneca, we received 3,200 doses this week. We're still not sure what our next batch is, but we also know that our pharmacies have been told they can receive up to 12,000 doses across the 10 pharmacies. So that's a significant amount of vaccine that will really help us move towards that herd immunity. Next slide, please. Okay. So now it's my turn to hand it over to Kyle so that he can talk about how we register and book people for the vaccine.
Thanks, Rita. So I think before we sort of turn it over to the registration system, the online booking and pre-registration system, we wanted to touch upon different tactics to reach the populations that are eligible for pre-registration and booking. So the communications plan has been significant, and we've been looking at a whole host of different areas in terms of looking at newspapers, radio, media relations, social media, digital and portable signs, and different print materials, and being cognizant of which tactics should be focused upon, depending on the age groups or depending on the subsets that we're taking a look at. This is just an example message from our communications department in terms of what we've been outputting on the different social media or media platforms, really pushing people to the registration website. So wdgpublichealth.ca/register. And then as the phase 1 and phase 2, and as things change in terms of who's eligible for the vaccination, we're trying to stay ahead of the game. Maybe 4 to 8 weeks out, and have people registered and in the registration system ready for their invitation for the online booking, so that when the time comes where the booking can occur, we have a whole host of names that we can pull upon to get our clinics filled as quickly as possible. So the pre-registration website, as I said, wdgpublichealth.ca/register. And we did a lot of videos. So the URL isn't friendly by any means, but it's available if you go to wdgpublichealth.ca/register. And there's lots of videos on before you pre-register, what should you know about, how to guide through the pre-registration system and what you should be doing there. And then also in terms of appointment bookings. So the wdgpublichealth.ca/booking is where you can actually do your immunization booking once you become eligible, and you get your email confirmation that you're eligible with your internal database ID to allow you to then register for your booking. And then there's more videos around before you book an appointment, what should you do, how to book your appointment, and guide you through the system step by step on each field, what it expects and what you should be typing in. And then also how to cancel your appointment in case you can't actually come, to cancel that appointment, to then open it up to others to be able to get their vaccination at that time. So as Rita spoke about, we have sort of two different systems in play. And this is a bit of a busy slide, but I'll start sort of on the top left with the prioritization registration system, or that pre-registration system. So this is where everyone in phase 1 has gone and everyone in phase 2, and then we're actually looking to open it up a little more broadly to have a whole host, a lot of individuals in the system to be ready for when vaccine supply increases and we have more and more appointments that we can work through all the citizens within WDG. So after someone registers on that system, every night we take a poll of who currently qualifies to book an appointment against how many appointments we actually have available. So that nightly poll takes the information out of the pre-registration system and then emails and texts all those individuals with information about, congratulations, it's now your time to book your COVID immunization. Please click on the following link. They click on the link and they're directed to the online booking site, which is at the bottom there. And then that's the site they go to click through to actually book their immunization appointment. In terms of a process flow, the client registers on the pre-registration system website. That prioritization categorization occurs in terms of the different priority sequence as deemed by the ministry, and that puts them into different buckets. And then our nightly process takes a look at the buckets and looks at phase 1 first, and then sort of works its way down to pick the names out, to pick the individuals out, to send them the invitation to actually do an online booking. The second step is around the e-booking process. So Input Health here, Input Health is our electronic medical record system, which also has an online booking module, which is what we're using for all of our online bookings. So the individual or the client receives that email or SMS text message with information saying, yes, it's your time, please book your appointment. The patient then logs on to the e-booking website with the internal database ID that's provided to them. They put in their information, they're sent a one-time code, which is different than the internal database ID, but the one-time code from a security side, we had to implement something to ensure that nobody could sort of hack the system and take all the appointments or sell the appointments to others. We didn't want anything to occur from a security aspect side of things that would cause a delay in immunizations for all of our constituents. And then, so the patient receives the one-time code, puts it in, and then it guides them through, okay, it's now your time to book your appointment. Please pick a date, a time, and where would you like to go? That being said, all of this is online, and we need to be able to reach everyone, both those that have the ability to use technology and go online and have computers, have laptops, have all those items, but some people don't. Some people don't have access to that or can't use the technology to actually do the online booking. So this phone number, which is on our online booking system, and we communicate out through all of our social media, different channels through our communication plan, is given to allow them to phone in. So just simply phone in, and if you qualify, you could actually do your booking that way. And we've actually expanded that system. So at the beginning, we were using our local on-premises or our telephone solution for WDG. but the number of calls we were getting was quite substantial. So realizing the number of calls and what was happening, we actually went to a cloud-based telephony solution and increased the number of agents on the line to be able to handle the call volume so that we can ramp up or ramp down depending on the intraday call volume. And with the new solution, our wait times are anywhere from, say, 5 to 10 minutes when you call into the call center, rather than before it was substantially more. When we take a look at the numbers, so the numbers in terms of the total pre-registration numbers within Wellington, Dufferin, Guelph, and then the percentage of those that have actually have a booked appointment or have been vaccinated. When we look at the phase 1 categories, the percentages are quite high. So when you're looking at 70s, 80s, 90% booked or vaccinated, we're quite proud at those phase 1 categories and those phase 1 booked or vaccinated numbers. And as Rita said, we're working hard now in phase 2 to bring up the numbers in phase 2 just as substantially. Also, we spoke about age-based. So when we take a look at the age-based and number of booked appointments or vaccinated in the various ages, it does decrease with age, but because we started in phase 1 with the 80 plus, and we're working towards getting the numbers higher and higher from that 60 to 80 years old category to ensure that as we go through the age-based categories, the eldest are immunized first. You may have seen this graphic. It's on our website. Quite proud. I took the screenshot today. We're at 20%. So 20% of our total eligible population have at least one dose, and our goal is really to get to 75. So as we move along in time, we're hoping that this gets closer and closer to 75 as quickly as possible to get that herd immunity that Dr. Mercer speaks of during board meetings or elsewhere, where we really can see a lot of change when we get to that 75%. So currently we have that 51,000 doses delivered, and it's spread out. So Wellington County, there's just under 17,000. Dufferin, we have 7,500, and the city of Guelph, just under 27,000 doses administered in those various areas, but 20% overall within WDG. Another graphic that we've shown is sort of through time how we're doing with doses administered per 100,000 people by geography. So on this graph, you can see WDG is actually the sort of darker blue at the bottom when you look at the left-hand side. And as we move through time and we receive dose at the health unit, we've actually been able to increase the slope of that curve or go at a higher exponential rate when we compare to our averages. And the averages we used were the Ontario doses administered, and then more federally looking at Canada and the doses administered per 100,000 population. And then again, with vaccination rates, looking at the chart below, looking at the doses of COVID-19 vaccine administered per 100,000 per region. Again, WDG being just over 21,000. And then the averages we're comparing to there being provincially and federally being above average in terms of doses administered per 100,000. And that was just pulled April 4th. I think I'm sending it back over to Rita at this point and talking about staff capacity and what our staffing levels look like sort of pre-pandemic to post-pandemic, and how we're working hard to deliver high quality service by actually increasing our staffing pools quite substantially over the past 1 year.
Thank you, Kyle. Do you want to go to, so there we go. So this is a really good presentation of our operations for our pandemic response and where our staff are. And as you can see, the two largest pieces of the pie are our nursing staff and our vaccine clinic staff. So just so people understand, the vaccine clinic staff are the support staff that work alongside our nursing staff and our community partners that come to our clinics to help vaccinate. The other areas are all the other staff that are continuing to work to move public health forward. important numbers to keep in mind is prior to March 1st, 2020, we had about approximately 150 or so staff, between 150 and 170 staff working with us. And that would be our normal day-to-day operations before the pandemic hit. We are now well over 300 people. We have doubled our nursing staff, and our clinic staff alone are close to 200 people. So when I tell you we have the ability to vaccinate 10,000 people a day with the support and help of our partners, we definitely have the ability to do so. This slide shows this enormous machine that has been working through this pandemic for the last year and a bit. And what I will tell you is that they are very dedicated. They're very passionate to get us through this pandemic. They answer when we call. This weekend, we had a significant increase in cases, so much so I don't think we've ever seen that many increases in cases. I made one call out on Saturday morning to all the staff, and I was overwhelmed with the response of a very tired, very exhausted team looking forward to a holiday weekend where they got some extra time off, and they stepped up to the plate. They came forward and they worked the entire weekend so that we could get through our cases and be able to have our clinics running and operational on Easter Monday. So I just want to let the board know that this has been the work of the entire organization, and it starts first with you as board members, giving us and giving Dr. Mercer particularly the opportunity to function utilizing her best clinical knowledge, her understanding of what's happening with the pandemic, and being the support system behind her when she does things like makes a decision to close schools because it's in the best interest of our community, ask residents to wear masks because it's in the best interest of our health and well-being. I also want to say that Dr. Mercer has put her neck out on more than one occasion, and it's just from my perspective as the operations chief, it has been amazing to work alongside her and have the support to be able to make the decisions that we have to make in operations to move this organization and this machine. It's a beast of a machine. Move it forward for the protection and the safety and well-being of our community. And that also extends out to the other senior leaders who have been very supportive of my role in operations and given me the tools and the support I need to continue operations moving forward. And then, like I want to mention again, it's the staff. They have stepped up more than one time, and I just can't say enough. And so I just wanted to take this opportunity to let you know how amazing it is to be working along such a dynamic workforce. So thank you, everyone. And next slide. So this is the time for you to ask us questions, and I'm not going to read what's on the slides. Those are just comments that people have made to date at our vaccine clinics, and just comments that they've made of their experience going through the vaccination process.
Well, thanks, Rita. And those words are well spoken. And as I said before, it's just great to see this and see the results that they're creating. And I just know if we can get the vaccines that we're going to get to the end of the road a lot quicker, and you're prepared and ready to do it. And I know from a government standpoint, working with all the counties and with the city, we've cooperated, and I know it's been really good cooperation and getting these facilities there for you and everything else. But I hear nothing but praise for the way we've run the program. And Kyle, I just want to say we got our online system up good 2 to 3 weeks before the province. And being smaller, you can be a little nimble. I'm not blaming the province for it. It's a big thing for a province to do something like that. But our IT department got that working and internally. And again, I think Dr. Mercer talked about our data science and all the other stuff that we have that we were able to do. And one of the things we forgot to mention was the fact that we went and got freezers way back last August because we knew Phizer was going to be one of the ones that we probably were going to have to use. And that's why our public health unit was one of the first ones that were allowed to have the Phizer vaccine out and showing how to do it. And I just can't praise you enough as to what we've done. And I know we can get to the finish line. So keep up the good work. Pass that on to your staff, please, from the board. Questions? I know that was a great report. I answered a lot of my questions, but if there's anybody else got questions. I can't see everybody. If Kyle, can we take down, there's a lovely comments. There we go. And I can see everybody. Okay, good. June, did you have a question or did they? Oh, Al's got one. Okay, over ahead, Al.
I just wondered, Dr. Mercer, with the numbers that you're anticipating, will you be able to move that, 16-week in between shots up? Are you anticipating that might happen?
Yeah, that's a really good question, Alan. And it's out of my control. I think we will have to hit, a place where we have more vaccine than we are able to give first doses. So I think it's entirely plausible. We still have a lot of people to vaccinate. I mean, we've only done, we only have over 50,000 people locally. So we have a lot of people left. If our base population is 255,000 people, if everybody was to take the vaccine, which we know won't happen, we still have a couple 100,000 people to vaccinate, and that's a lot. So I hope so, but I won't know that until we get closer to June. My suspicion is based on what I saw in the first quarter. Most of our vaccines seem to come in the last few days of the quarter. So the federal government says, yes, we're getting so many million doses in the first quarter, but they came on March 31st, and some of my first quarter doses actually arrived on April 5th. So even then it wasn't in the first quarter truly. And most of the doses which are scheduled for the second quarter are scheduled to arrive the very last week of June. So again, it's not equal, and it makes vaccine scarcity, makes it challenging to manage the pandemic and provide the vaccines that everybody wants as fast as everybody wants them.
Thank you. And I echo George's words. I think that the staff and yourself have done an excellent job in rolling us out. So,
thanks, Al. June, go ahead, June. Oh, sorry, June. I can't hear you.
I think it might be a microphone issue, June. You are unmuted. If we want to move to Rodrigo, also put his hand up. It's
okay.
Up to you.
Go ahead, Rodrigo, and then we'll get back to you, June, if we get that fixed. Okay, thank you. Go ahead, Rodrigo.
Thank you, Mr. Chair. Through you to staff, I had a follow-up question about the registration. I understand that we're putting the word out there through social media, through the local news, but to people that are not following those channels, that may not be following public health on social media, do we have a plan to do a widespread mail drop for the entire region? And I'm wondering, when would that need to happen if you're still getting enough calls that you're filling up your vaccination times? At what point do we look for other methods to make sure that we're getting everyone, even if they're not following public health on social media?
Thank you, Rodrigo. I don't think that we will be anticipating a mail out. I think the cost of that would be pretty horrific, and it would actually probably be an environmental waste too, because we've already immunized. We have in our registration system, just rough guess, people we've done and people who are registered, over 100,000 names across the area. So those are adults, or we don't take into account children. So if we were to do a mass mail out, we're going to be emailing or mailing to a lot of people who've already been vaccinated, for example. So I think we do need to look at what routes can we use, if there are municipal routes, if there are, what other places can we utilize that are already going out. And as I said, I do weekly TV. We try to get our libraries involved. We're trying to put posters in workplaces. We're trying to target through our community health centers, our physicians, our, so if there's other places that we are missing that we should be using to try and get the word out, we're more than happy to hear about it. Though I'm sure Anna, I can see her on this call. I'm sure she'd be thrilled to know if we're missing something, because we are trying very hard for people to know, and in multiple languages too. We've been involved in the immigration services so that we make sure that those who don't speak English can also receive this for our new Canadian residents of Guelph.
Great. Thank you very much, Dr. Mercer. I appreciate that. Another question that I had was about the efficacy of the vaccines with the new variants that we have in our community. I just wanted to hear from you whether there's any concerns about the vaccines that we have and that we're giving out, whether they're equally effective with the different variants that we're seeing these days.
Oh, you're preempting my board report, which is next. Do you want to hold your?
I'll hold that to the board report.
Yeah, we'll hold that thought. Yeah.
I just wanted to, in closing, echo my other board members. I think that you're doing an excellent job. I think it was the right move to close the schools, looking at where the infections are happening and the rate of infection. I know it's very difficult for our community members, and I'm hearing from a lot of people that are very frustrated and they're angry because this keeps on happening. But I did have one person say that they endured the Second World War, and we have it a lot easier than they did back then. So for a little bit of perspective, it's short-term pain for the public good. Thank you.
Thank you, Jiga. And I recognize it, in particular for women, that schools closures is devastating, from an economic, I think we're going to look back over this pandemic and see that in particularly women have been impacted more as throughout the pandemic with all the school closures. And I think that people have said that it has set women back in terms of their income levels, and their amount of women in the workforce has fallen precipitously throughout the pandemic for a variety of reasons. And so, yes, this is not good. So we need to get our children back.
June, are you all good now, or can we hear you? No, we've lost you. Okay. Christine.
Maybe she could just email her question to Sylvia.
Yeah, or put it in chat if you want. We'll if you can, June, if you put it in chat.
No, the chat box doesn't work, George.
Oh, that's right. We don't have.
But you could email them to Sylvia. Or
go ahead, Christine.
Through you, Mr. Chair, it was mentioned the pharmacy sites, there will be 10. And so in our area, when they're up and running, do you still have to register, pre-register, or is it going to be first come, first serve at the pharmacies?
So yes, a great question. So pharmacies are a very different model than the public health model. So the vaccine that's being distributed to pharmacies, which is the AstraZeneca vaccine, does not go through public health. So it goes from the province to pharmacies directly, and pharmacies do not have to follow the same prioritization framework that we do. They give it to anybody over the age of 55. In our area, though, we have a very high rate of coverage of people who've got appointments or have already had the vaccine over the age of 60. So they may find that it's predominantly being used in those between the ages of 55 and 59. So I'm not part of that. What I do know from the pharmacy rollout in other parts of the province is that they saw large numbers of people commuting from outside of the area that had the AstraZeneca. The pharmacies were chosen by the province. There was only 2 pharmacies, I believe, on the list. Or is it 2? Yeah, Rita's showing me her 2 fingers. So there were only, we submitted a list of many pharmacies that we wished to be included in the pharmacy rollout. And predominantly, we were looking at pharmacies that served underserviced areas. So parts where we knew that we needed to increase access. So places where they didn't live in a community with a mass immunization clinic. Maybe they didn't have a primary care a physician. So that's where we were actually targeting with the pharmacies. I do believe that a lot of those pharmacies will be included in the next round, but currently they are limited to only to the pharmacies that the province selects us, which was, oh, I think June, you're working now. I heard you. So yay.
Right in the middle of Christine's question. That's all right.
Yeah, so the pharmacies, I believe you have to make an appointment with that pharmacy, but I don't even think you have to be a client of that pharmacy. I think you can just call up any pharmacy and say, hey, do you have vaccine? Can I register?
Okay. And then phase 2, under the chronic health conditions, you could be any age, right? You could be 30. You didn't have to be 60 or older. Is that correct?
That is correct. Yes. We haven't, I mean, a lot of that's going to be done through primary care. So when we get our next Moderna shipment, we've started with primary care offices, and we will be delivering vaccine to primary care offices again when we get more Moderna, because primary care physicians in particular are really well positioned to know who amongst their patient population is most at risk and who would benefit the most from it. So that's part of the strategy, is to use our primary care to help with the at-risk and the high-risk medical conditions.
Okay, so then if you book and you book your site to be, say, the West End Rec Center, so then typically you would get Phizer there,
if you book into a public health mass immunization clinic, you are most likely going to get Phizer, not exclusively, but I can say you'll be getting an mRNA vaccine. And just while I have you here, both of our mRNA vaccines, they're actually identical. They're biologically identical. They're just wrapped in a different coating. So it's like buying two presents and wrapping one in red and one in blue inside the same. The color on the outside is different. So both of our mRNA vaccines, the message that is delivered to the cells is biologically identical. There's actually been some studies and some thought about whether, if you had one, could your booster be with the other one? Like, does it have to be the same one? Currently, we're doing the same one, and that is what the manufacturer recommends. But there actually has been some studies that look at mixing and matching, because the vaccines do the same thing.
So if that's the case, and that's the only difference, is the rate of getting COVID arm the same then for Phizer as it is Moderna? And the reason why I'm asking is because they're calling it Moderna arm when you get a reaction. And so you get the rash, you get the itch, you get the swelling, even though it's a low percentage. Is that just more for Moderna, or are you seeing it in Phizer vaccinations as well?
We're seeing it in both, but I would call them typical vaccine reactions, like that we see with many vaccines: sore arm, a little bit of a rash, a little bit of an itch. Occasionally people feel a little bit unwell a couple of days later. But I would say that the local reactions, in fact, I would say the local reactions are actually less than what we've seen with the shingles vaccine. I think the shingles vaccine is probably one of the ones that we see the greatest number of systemic and effects after, as people can be not very well after they receive their shingles vaccine. But in general, most people are better with the first one, sometimes a little bit worse with the second one.
Okay. Thanks, Dr. Mercer.
Thanks. June, are you up and running there?
Can you hear me?
Yes.
Oh,
Kim.
Thank you, Kyle, for your support. I was talking to you on the phone. I just wanted to, I'm happy that you can hear me, because there were a lot of milestones shared in the presentation by Rita, and I would like to thank and acknowledge Rita and Kyle for the presentation. I will say that yesterday I got my shot at the West End Rec Center, and Rita referred to it as an enormous machine. Well, I can tell you, it was seamless, it was friendly, it was really well organized, and it was such a caring environment. So hats off. I heard lots of positive feedback from people that were also participating in their first shots. I just had a question about the, so 20% of the population of the WDG have been vaccinated, and your goal is 75%. This was on one of the slides, I believe, that Kyle showed. Is 75% for the first dose?
Yes. We're hoping to attain 75% of the first dose. Ideally, if we get higher, that would be great. And then we'll move on to what we call complete vaccination. So we do have a few people locally who've had a full vaccination. All of our people in long-term care retirement homes, they've had 2. And there were some people very early on, some healthcare workers who've had 2, but most people have only had 1.
Thank you, Dr. Mercer. And Kyle, I just have one other question around the registration. And I wondered if you could help So for people that registered or thought they registered and did not get a confirmation email, should they go back in and re-register?
Let Kyle answer this one.
For you, Mr. Chair, I wouldn't go in and re-register if they got to the final page that says you have registered, your data has been submitted. There was an issue with volume at one point where the email server couldn't keep up with the thousands of registrants that were happening with the time period. So I wouldn't go in to re-register unless they didn't get to the final page that said, confirmed you have registered, because some people were getting to the final page that reviews the information and not hitting submit your registration at the bottom, thinking they registered because they see their information, but you have to hit submit your registration. As long as they hit submit, the data's there.
Okay, so what if it's been a couple of weeks and they still haven't heard? Would you recommend that they go in and register? I'm one of those people, so.
If they're part of phase 1 category,
Yep.
Or if they're in the 65 to 80-year-old category,
Yes.
I would phone the phone number on the online system to get to the call center. With our call wait time being so low now with the hardware and agent improvements we've done, they actually have all the information to book the person's appointment, and they can go in and then find them in the registration system or find them in the online booking system and do the booking right then and there. And then at that point, if they're saying, well, we don't see you, they can give the information and give their age, and then they'll get their appointment booked then and there. With the wait time being 5 to 10 minutes, I think the quickest way would be to do that method rather than go through the online if they fully qualify, especially if they're already in the registration, because we've had some issues with people registering multiple times, which then gives issues for that person trying to register because there's too many like names in the system with like information, and the system's thinking it's spam.
Perfect. Thank you for the solution and the options, Kyle. Thank you very much.
Okay. I think we can move on, and we're going to have some more discussion on vaccines. And oh, Ralph, do you have one? Go ahead. Got to help Ralph out there, get him off his.
We're clicking on we're clicking on the unmute, Ralph. You're going to have to click on the button that says
There you are. Okay, go ahead, Ralph. Ralph, did you want to ask a question? You're not hearing me. Technology. Okay, well, hang on to that. If we okay. We'll get back to Ralph in a minute. I think we want to move on, Dr. Mercer, to your board report. Time is getting up there. Just one quick question I had when you were saying about the pharmacies. I assume they have to register in the system, though, so you would know that they're off your list, right? Or
the pharmacists do have to put into the system the clients that they register.
Yeah. So then that would show up in our number, right?
Yes, and what we have seen in the province is people go and get AstraZeneca at a pharmacy, and then days or weeks or later try and get Pfizer at a mass immunization clinic. So, and they can't. So the system is that you're only allowed one vaccine at this point in time until everybody's had one. So for people who are thinking they will start with AstraZeneca and then they will move to Pfizer, no, that's not going to work. And once we get the you in our clinic and we discover that you've had a vaccine, then unfortunately you'll be declined to go and get a second dose.
Thank you. Great report, everybody, and great questions. So I'm going to move on to the Board of Health reports, and it's Dr. Mercer's report. I think we don't have Dr. Tannenbaum. I don't.
Well, yeah, I was going to say this. Yeah, this is actually Dr. Tannenbaum's report, but Dr. Tannenbaum yesterday morning, his wife had a baby, and so he's going to be off for a few weeks. So it's his first. Yay! I know a little girl, Sophie. I don't know if there's a middle name, but I just know it was Sophie. So yes. So he was going to deliver this report, and now I'm going to be a poor substitute for Matthew. One of the things that I can say is this is a tough report to write because I think he had to edit it about 3 times, and I'm sure sure there's probably a few little bits of it that may have outdated because the information is moving very quickly. So we tried very hard to get it as close to the board time as possible in order to have the most accurate information. So I'm going to just say that I think it's fairly clear. It looks at all of the 3 vaccines, but I'm just going to focus in on the question that Rodrigo asked me earlier, which is about efficacy and effectiveness. And so let me just get my report out here. So the 2 are actually not the same. Okay, so so I just think people sometimes look at the 2 and think, okay, so this is what people think. They think if something is 90% efficacy, okay, they see that, they think it's 90% efficacy. That means that for every 100 people who get the vaccine, 90 people won't get the disease and 10 people will get the disease. That's, I think, what people think, and that is not true. It's an absolute reduction, and it depends on what you're measuring. The other thing about this is that often the efficacy trials are done in lab or in perfect circumstances. So people come in and they get perfectly accurate doses by people in a lab controlled environment, and then they come back on a set schedule. So it's in a very controlled environment. Whereas then there's real world. What happens when it goes out and it's being given by regular nurses, physicians, pharmacists through those delivery channels? So sometimes that looks quite different. As we've gone through this pandemic, you have to remember that a lot of the vaccines were done in real world settings. So here we are, we're testing a vaccine. And if you were testing your vaccine last May or June, you were probably testing your vaccine at a time when the only thing that was circulating was what we call the wild type, which is actually slightly different than the one that originated in Wuhan, but it's the one that really spread rapidly throughout the world. But now, if you were testing your vaccine, so manufacturers who came out a little bit later, after the Pfizer, Moderna, and the AstraZeneca, those manufacturers are testing their vaccine in a different world. Which is why the manufacturers of AstraZeneca, when they were doing trials in South Africa or Brazil or India, where you have very different variants of concern that are circulating, we actually see real world data. So that's what we're seeing. What we can say is that we have some evidence of emerging evidence that suggests that the vaccines, all of our vaccines, are effective against the UK variant. So that would be whether it's Pfizer, Moderna, or the AstraZeneca. And there is definitely evidence that all 3 may be less effective against the less common B1351, which is what you would call a South African variant, or the P1 variant. Now, B1351 and the P1 variants, Brazil, South African variants, they contain additional mutations. And so really what we're saying is, let me just paint this picture. So the vaccines are created to create antibodies against the spike protein, those little things that stick out of the cell. That's what we're making antibodies to. If those spike proteins change, the question is, how much do they have to change before the vaccines that we're creating to make antibodies, before they don't work anymore? And so we think that, and there was a recent study by Phizer where they said that their vaccine, and it's a small study and it's only one, where they said that their vaccine, the Pfizer vaccine, is actually 100% effective against the B1351 variant. So that's a really promising sign that is. And Moderna has already said that they see reduced efficacy, and the AstraZeneca was not very effective against the South African variant. Again, they're all doing the same thing. They're all helping the body, teaching the body to create antibodies to the spike protein generally. They do it in different ways. One's a non-replicating viral vector, and the other is a messenger RNA. But interestingly enough, all 3 of these vaccines that we've got out, and still just very soon to come, the Johnson & Johnson, these are all new vaccine technologies. These are not the vaccine technologies that we have when you go to your doctor and you get your tetanus shot, when you get your flu shot, your shingles vaccine, or these are based on very different technologies. which is interesting, and it's much faster, clearly, in order to get these vaccines out. So what I can say at this point in time is that in our area, it's the B117, the UK variant, which is circulating, and we have good reason to think that a single dose of Pfizer, Moderna, and AstraZeneca, we want you to get the second dose, but right now the single dose will prevent severe disease, hospitalization, and death. So I'm not telling you it will prevent people from potentially testing positive or having mild disease, but it's going to prevent people from dying. And that is really, really important for people ending up being hospitalized on a ventilator and dying. And so that's why locally and in Ontario, we are trying to get all three of these vaccines out as quickly as we can in order to ensure that we save as many lives as we can. And this is not going to be your last vaccine. I can guarantee that. You know, if the variants change and if our vaccines are not effective, you're going to need a booster. And in fact, I can't even promise you that you're going to get the same vaccine. So you might start off with Pfizer, and studies may show that the best approach is if we combine an mRNA vaccine with a viral vector vaccine, or maybe with a protein subunit vaccine, or maybe and there's a few others that are out there that are a DNA vaccine. So eventually down the road, science, technology, the medical world will say this is the best approach to this coronavirus, which has only been around, if we think about it, since just over 15 months, 16 months. So the fact that we even have vaccines, the fact that we even have anything that's protecting people right now is nothing short of remarkable, nothing short of a really huge step forward for medical science, and that is going to have long-lasting implications for vaccine technology, influenza technology for generations to come. Generations. This has just been, so for all the bad that's happened, and there's been much bad with COVID, there have been some technological advances that would never have happened. We would never have an mRNA vaccine without the money and the time and the urgency that we needed to have an mRNA vaccine. And so we'll be taking this forward. So this is a report that just tries to summarize in some plain language where we are, and looking at the safety, the extended dose interval. Remember when Matthew wrote it, he didn't have today's NACI statement, so which is even supportive, which is continuing to support even further what is in this report. So I hope that answers your question, Rodrigo.
Thank you, Dr. Mercer, and pass on our good wishes to the family, and hopefully has a couple of weeks that he can really enjoy not sleeping at night once the baby's home, which he hasn't understand that yet, but he will get there. So I've got a report that the Board of Health receives the BOH report, BH01 APRO 721R03. The current status of COVID-19 vaccines in Canada is presented for information. Can I have a mover and a seconder for that? June and Christine. And any question or any comments? I think it's well laid out, and it was a good read. Okay. Anybody opposed? Okay. Going forward, we have no executive report, no human resources report. Now I'm turning it over to Board Member Chris White to do the chair of the audit and do the audit report today. Thank you.
Thank you, George. And I understand Dr. Tannenbaum's new child. The middle name I actually know, it's George.
Is it really? Oh, I did not know that.
Yeah.
Well, that's great to know.
Yeah.
We're from the Kings, from the Kings. Anyway.
Okay. I might need some help with Sylvia here if I go off the rails, because I got a bunch of different reports. I'm not sure what exactly I'm doing with them. So we had a insurance program review update, and as everybody knows in the insurance industry these days, with weather events and COVID and all kinds of other pressures, insurance rates are going up. And I think we had this conversation a couple of meetings ago, and the board is doing the best they can to try to keep things in line, and we'll continue to keep an eye on that. So we received a presentation on that, and we have a report in the package. It's the Finance and Audit Committee report, BOH 04, April 07, 21, 03, 2021 insurance renewal. I'm going to ask for a mover on that and a seconder, and then I'll take questions. Moved by Al, seconded by June. Are there any questions on that report for approval? Any opposed? That is approved. Thank you. Then we had a staff summary presentation on the draft audited financial statements. And I don't think we need to approve that here because we've got a report in a moment. And then we had a KPMG audit findings report with an update for information. And just to touch on, I think we should all remember as well, from a financial perspective, all the great work that the board has done out in the community. There's another engine firing away down inside, which is the financial engine. And as I mentioned in our finance committee, we started off the beginning of last year with a whole new potential structure, depending on what the province was going to do to us. So we were trying to figure out how we were going to handle the finances then, and then immediately had to switch gears. We went into COVID. At the end of the day, we've come up, we have had some COVID funding, but staff have worked tirelessly, and we have a surplus. And if you consider how much more staff time has been involved, and I mean, just how incredible this operation has been, it's fantastic to see that the financial side of it has been kept perfectly in line, and the auditors and so forth see that. So I'm going to put the audited report and financial statements on the floor, and we'll see if there's any questions. I have Finance and Audit Committee report BH04, April 27, R04, 2020, draft audited financial statements. And I'm looking for approval for that. Moved by June, seconded by Guy. Are there any questions on the financials? George.
I just comment, Chris, if I want to just say that the province has stepped up. They talked about it at the beginning, and the minister said, because they put this on public health, and a lot of people don't understand public health is funded by municipalities, big portion of it, not by the province. So the fact that they did step up to the plate, and as you said, there's a lot of work in figuring out what COVID expenses are and the extra people that we've had to hire and everything else, but they have been good about coming to the plate and making sure we didn't fall into this going back on the municipal tax base. So I give them credit for that.
And thank you, George. I think that's important to point out because, again, beginning of last year, municipalities included and agencies like the conservation authorities and everybody didn't know where we were going. You were looking down a rabbit hole, and every step of the way it was a moving target. So again, great work on behalf of Dr. Mercer and her staff. So thank you for that comment, George. Are there any questions on the financial statements at this point, the draft version? All right, any opposed? That report is carried. Thank you. And finally, we had this is a standard report. We've got the BH04, April 27, 21, compliance report, stewardship of management operations. Again, that's an oversight report coming out of the province. Can I get a mover for approval on that? Moved by Christine, seconded by Al. Any questions? Any opposed? That is carried. Thank you, George.
Thank you, Chris. Well done. And number 10, there's no correspondence. So now we're moving into closed session. So I need a motion to move into closed. I got June and I got Guy. Anybody opposed? No. Okay, so Kyle, you have to let us know how we're doing this. I think we go out, don't we? Christine, go ahead.
Yeah, that's what I was going to ask. Can we stay right where we are? Or do we have to go out and go into the other closed?
Well, that's what I was going to ask Kyle. I think we're supposed to have we have to come in on a different line, right?
We have to?
We have
Yes.
the closed session Zoom link to open up. And then once we're all back in, then we could start a closed session.
So has everybody got that link? If they don't have that link, let everybody know, okay? Or let Kyle know. Are you good, Christine?
Yeah, okay.
All right, yeah. Okay, technology-wise, we're going out. We'll see everybody in a few minutes.